at the top of the hour. Hi, everyone. Welcome to today's presentation in the NNLM Rural Health Webinar Series, Social Connectedness and Improving the Health of Rural Communities. My name is Erica Lake. I'm the Health Sciences Librarians Outreach Specialist for Region 6 of the Network of the National Library of Medicine, and I'm going to be your host today. Since some of you might be first-time attendees to one of our webinars, I'd like to share just a few words about who we are. NLM, the National Library of Medicine, is one of the 27 institutes and offices of the National Institutes of Health. It's the world's largest biomedical library and produces online resources like PubMed and Medline Plus. NNLM, the network of the National Library of Medicine, is the education and outreach arm of NLM, providing free training to librarians, health professionals, and the public, as well as engagement and funding opportunities for health information. NNLM is made up of 7 regional medical libraries, 3 national offices, and 4 national centers that connect with our 9,000 NNLM member organizations. If you'd like to locate your regional medical library or learn how to become a network member, you can check out our website at nnlm.gov. So this month, the NNLM Reading Club is also focusing on rural health. Every month, the Reading Club recommends 3 health-related titles that can be used for a book club event in your library. They provide marketing materials and discussion guides, which can be downloaded from the NNLM website, and share links to authoritative information from NLM, NIH, and other health agency resources. In conjunction with this webinar series, NNLM has created a new rural health resource guide that pulls together general information on rural communities and rural health, as well as resources and information addressing special issues. And we are going to put a link for the guide into the chat so you can explore that on your own. And now it's my great pleasure to introduce our speaker for today's webinar, Dr. Hannah Fields. Dr. Fields practices family medicine at Madison Healthcare Services, a rural critical access clinic, hospital, and nursing home facility in southwestern Minnesota. Originally from Colorado, she graduated summa cum laude with a BA in biochemistry and psychology from the University of Colorado. While studying medicine at the Mayo Clinic in Rochester, Minnesota, Dr. Fields was awarded a scholarship for a Master's of Science of Public Health at Pompeu Fabra University in Barcelona, Spain. There, she developed a pilot program for prescribing social activities to address isolation and social health determinants in rural communities in Catalonia, Spain, and then returned to the University of Colorado to complete her family medicine residency training. And Dr. Hannah Fields is joining us from Colorado today, so we can get a beautiful view out our window. So welcome, Dr. Fields. I am now going to turn off my camera, and I'm going to turn the controls over to you.
Hello, everybody. Thank you so much for joining today. It's really a pleasure to be here and to have a chance to speak with all of you about something I'm really quite passionate about, which is social connection, and especially the ways in which we can work with social connection to improve the health of our communities. Bear with me just a moment while I get my presentation up for all of you. Okay, can you see it? I hope so.
Looks great.
Thanks, Erica. Okay. Perfect. So this is social connectedness and improving the health of rural communities. And thank you for the introduction, Erica. I'm Dr. Hannah Fields. I have nothing to disclose. The learning objectives for our talk today include to understand the impacts of social isolation and loneliness on health, to identify risk factors for social isolation among members of rural communities and other communities, and to describe possible community and health interventions which can improve social connection and therefore health of rural community members. So first, we'll start with some definitions for loneliness and social isolation. So we all have an idea of what these might mean, but when we think about this technically, we're thinking about 2 interrelated concepts. One is basically objective and the other is subjective. So social isolation is an objective measure of the lack of quantity of a person's social relationships, social contacts, roles, group memberships, and interactions, meaning lack or presence of connections. And loneliness is a personal or subjective experience of a lack of desired or meaningful relationships and social contacts. So many people who experience social isolation might also experience loneliness. Of course, there are people who may identify as lonely, but are not socially isolated, meaning maybe people whose relationships do not fulfill the connections that they seek or that would fulfill their life. Or there might be people who would be considered socially isolated with few connections, but say, no, I'm not lonely. So the relationship may be complex, but it's important to keep in mind, as we discuss here, that either or both are both risk factors. Whether or not you feel the loneliness, if you are isolated, you have risks for poor health. On the flip side, social connectedness is really the opposite of loneliness and social isolation. It's defined as the diversity and size of a person's roles and social network, the positive and negative qualities of those relationships, and also the functions that they serve. So again, the opposite of the subjective and objective loneliness and social isolation, and it has both subjective and objective qualities. Social connection, being the opposite of loneliness, has the opposite effect on health, as we will discuss here. So again, both loneliness and social isolation contribute to really serious health and social outcomes. And we'll list just a few here from the literature: anxiety, depression, dementia, sleep disturbance, stress, coronary artery disease or heart attack, cerebrovascular disease or stroke, diabetes, poor health behaviors, which of course can be associated with all of the above, diminished immune system functioning, which can also contribute to increased systemic inflammation and contribute to all of the above major health problems and others down the line, including cancer, increased healthcare costs or utilization, and also to death. Social connectedness decreases these adverse biological illnesses and also has positive effects on mental health and health behaviors, and then decreases risk of having a serious illness or dying. So when we look at this relationship, we see that a lack of connectedness directly increases risk of developing heart disease by 29% and stroke by 32%. And loneliness and social isolation increase the risk of developing dementia by 50% or perhaps more in older adults. This lack of connection is comparable to other really significant risk factors for developing these severe health outcomes. Either smoking 15 cigarettes, so most of a pack of cigarettes a day, or more risk than drinking 6 or more alcoholic beverages each day, which is quite dangerous to your health. Loneliness, especially, increases risk of premature death by 26%, and social isolation increases risk of premature death by 29%. And to give you an idea of the scale of these impacts of adults in the US, 1 in 3 identify as feeling lonely, and 1 in 4 could be characterized as socially isolated. And again, keep in mind, these people aren't all in the same category. There are people who are not isolated that feel lonely, and there are people who do not identify as feeling lonely, but still have risks because of their social isolation. In response to this very significant health problem facing our entire country, the Surgeon General released a report last year in 2023 detailing the increasing risks of social isolation and loneliness here in the United States, and gave some insights into some general trends over the last several decades in the United States that are probably contributing to this. People spend more time alone, increasing amounts of time alone, 24 hours per month more alone than in 2003. And spending time alone isn't necessarily a bad thing, but this is time that people are not having the chance to build or form or strengthen their social connections or relationships. Smaller family sizes overall and decreased intergenerational living, of course, decrease the quantity of social contacts and potentially the quality of relationships that people have at home and in their family. And similarly, more people live alone increasingly over time. Only about 13% of households were single-person households in 1960 versus 29% or almost a third in 2022. Over the same time, there also has been lower membership in community organizations. And while, as you'll see later, there are a number of different community organizations that could affect social connection, church membership is something that has been tracked and studied. And so we see that even just in the last 20 years or so, we're down from 70% of Americans identifying as belonging to a church or religious group, down to 47% in 2020. We also think about the complex role of technology in changing our social connection and decreasing social connection. Well, there are certainly some parts of technology, such as Zoom and FaceTime and forms of communication that maybe could help us connect and maintain or strengthen our relationships. There are other forms of technology that certainly decrease the amount of contact and connection that we have, especially with people around us. As great as it is to use Amazon.com and be able to get things like Italian pizza flour and the, face lotions that I like living in southwestern Minnesota, every time I use Amazon, I'm not going to a store, I'm not seeing a neighbor or interacting with a cashier, and I'm not getting that opportunity for social connection. And finally, it's very important to mention that, of course, we are more likely to form connections with people that we trust. And for many, many reasons overall, there is decreased trust between American citizens, decreased trust of each other that has accelerated recently. And this certainly contributes to making us feel more lonely and to our health. So there are also many factors contributing to connectedness. And to think about this, I like to look within what's called a socio-ecological model, or sort of looking at the layers in which we interact with the world around us, especially when it comes to connectedness. So on an individual level, demographic factors, these could be things like age, gender, the cultural or racial groups that we belong to, can affect our ways that we connect. We do know that as people get older, for example, and may experience more health problems, that they're more at risk for having less connections or social isolation. And we'll speak more about that later. Health status on an individual level can certainly affect people's ability to form and maintain social connections, especially with a significant mental or physical illness that might take a lot of your time or energy or confine you to a certain area that could be a barrier to connecting with others. Sensory characteristics, along with other disabilities, can hinder our ability to even communicate, especially there's been attention recently to the importance of hearing aids, which we'll discuss more. And some individual characteristics, like the type of personality and our preferences, can influence how and how much we connect. And finally, on an individual level, socioeconomic factors, especially socioeconomic hardship, can be a barrier to having the time and energy and ability to connect and maintain some kinds of relationships. Then moving outward, so on the level of an individual and the relationships with those around them, some factors could include the household that they live in and the structure of the family or other people there who they would connect to. The structure and function of other relationships, including whether this person may be employed and have a collegial type relationship. The quality or type of relationships certainly affects connectedness. And when we think about quality, we know that not all relationships are equal and that some actually may be deleterious, including strained or abusive relationships. The amount of empathy that a person has or shares in their relationships, of course, affects that connection. And then characteristics of others that they might have relationship with. The other's individual characteristics certainly affect the connections. Then moving further outward, if we look at the community level, we know that many aspects of the built environment, including the type of housing or communities that people work in, the geography of the area, which is particularly important when there could be barriers, such as in rural communities or communities that are more dispersed, the type of workplaces that are available or the businesses that people can patronize where they could have or not have opportunities to connect, the presence of community organizations of various types that can help provide services or activities or groups to belong to, such as service groups or churches, the transportation that is available to be able to physically connect with others that are nearby your area or not, and then also the healthcare, social services, and others that can help affect those individual and relationship characteristics. And finally, on a societal level, the values and policies of a society, the availability of different types of technology and the role in that technology to influence relationships or enhance or harm relationships, inequity and inequality, which are consistently tied with poor health outcomes on a societal level, of course, would also be associated with poor health outcomes associated with social connectedness. The norms of a society regarding how we treat each other, communicate, and connect with each other. And as mentioned before, trust and openness to connecting with other people in society around you on a much larger level can affect our individual and community health via loneliness and social isolation. So based on this, in the global literature on loneliness, a number of risk factors have been consistently identified for social isolation and loneliness. These do include poor mental or physical health, sensory impairment, or other disabilities. Older people, especially given that older people are at higher risk for having poor health, sensory impairment, or chronic illness. Men have in many studies been identified as at higher risk for social isolation and loneliness. This may have to do with, in some societies, including in some Western societies, the perception that men are less likely to participate in nurturing and caregiving roles or kin keeping, which is maintaining connections between friends and family, and that this could place men at higher risk for social isolation. Financial insecurity or low income. People who live alone, who of course don't have access to the connections with others in their home environment where they would spend a significant amount of time, or also to the social networks connected to others in their home, would be at much greater risk for loneliness or isolation. Single parents or caregivers whose time and connection may be devoted to one person are at risk of losing the quality or strength of other connections in their wider social networks due to the caregiving that they perform. Younger people are at a higher risk for perceiving loneliness, while older people are at a higher risk for perceiving social isolation or for experiencing social isolation. In older people, this may have to do with the fact that they have a number of connections maintained in their life, but as they may develop more health challenges or transportation or even economic barriers, that they have a lower quantity of connections, even if they have maintained some relationships over the course of their life and may not feel as lonely. Minorities or any people that could be experiencing discrimination would be at risk for not connecting with others. And then finally, rural residents are consistently identified as a group who's at higher risk for both loneliness or social isolation. So let's think about why our rural communities might be more at risk. There are some unique circumstances and trends affecting rural communities, such as my own community in the United States, in Madison. We do know that overall, rural communities compared to urban communities have declining populations as people may need to leave the community for work opportunities or educational opportunities or other reasons, and aging populations. Again, many of the younger residents may relocate to other areas for different reasons. Rural communities tend to have lack of public transportation, which is a physical barrier to connection. Rural communities are at risk for having much more limited resources for healthcare or social services, which again, on an individual level, can be a strong influencer of social connection. Geographical isolation is powerfully influential. And especially when we consider that in our rural communities, we have community members who may live within kind of the rural core community, like within a small town where there are more individuals and other businesses, groups, social settings that are close at hand, or maybe better access to healthcare, public transportation, versus the members of our communities that may be in a more spread out or isolated setting, on farms, for example, or people who live in mountainous or other natural areas that are separated from others in a physical sense. Rural communities on average have lower incomes, which does increase risk for worse health outcomes and social isolation. Trends towards reduced intergenerational living can help create less cohesive communities in some cases and can impact the feelings of loneliness and the number of connections. And limited opportunities for socialization, including the amount of groups, resources, physical spaces available, also known as social infrastructure. And we'll come back to that in just a minute. When we think about rural communities, though, I think it's so important that we also talk about the positive aspects of our communities that can help promote social connection and give us a real strength to build from while we try to support our communities in this way. We do know that in rural communities, there is much more interconnectedness of individuals versus in urban communities. For example, I have a friend in Madison that I work with in the hospital. She's a nurse, and we'll joke that today I'm wearing my nurse hat. And, you know, she wears a lot of different hats. She is a grant writer, and she volunteers for the ambulance, and she volunteers for the school. And many people have a number of different roles and interact with each other across community settings. There also is increased participation in rural communities, including in organizations such as religious organizations, generally compared to urban or suburban communities. All of this contributes to more social cohesion and less isolation, even if just through seeing the same people on a regular basis. When you go to the post office or go to the grocery store and go about your activities, you're more likely to recognize people and not be anonymous, which we'll discuss more in a moment. Increased volunteering, and increased levels of participation in other informal support, things like babysitting for a friend or a relative when they need to take care of something, or going to feed your neighbor's dog if you know that they're out of town. These kinds of things that help us stay connected and build relationships. People who live in rural communities overall have larger social networks, especially older adults who tend to be deeply rooted in their rural communities and may have formed a number of relationships and connections over time. And then finally, a great strength of rural communities is that they often have greater resilience to hardship and support within community members than people experience in urban communities, including with great hardships such as natural disasters. So when we think about rural communities, I think it's really important to introduce the concept of weak ties, even though I don't really like the name weak ties because it does seem to imply that this might not be important. However, these weak ties are casual or acquaintance type relationships that play an important role in connection. And some examples of this would be speaking with a store clerk or a barista, seeing your neighbors and greeting them on a walk, making small talk with coworkers or others in a place of business that you might frequent, or even online and social media contacts that may not be your strong ties, your close friends, family members, you know, best friends, but people who nonetheless are part of your community and part of your group. And we know that an increased number of weak ties or these casual social connections is associated with lower risk of suicide, less depressed mood, and also greater positive mood and greater sense of belonging, i.e. connectedness. So even just having a smaller subset of people that you interact with and that you might recognize, you say hello or ask, how are you doing? You acknowledge them, you feel acknowledged. And even if that's just a moment, you have the chance to see yourself as recognized as part of a larger community. And this does decrease social isolation, loneliness, and the health risks associated. And it is a strength of rural and smaller communities. So here's an overview of some of the interventions contributing to connectedness on a number of levels. But we're going to kind of break this down and start with looking at the ways which on an individual level we can impact in our community's connectedness. Many of these have to do with the services that we may provide in healthcare, or medical services or social services, including addressing sensory deficits. For example, if we can identify someone who could benefit from a hearing aid, we can greatly decrease the chances that that person could develop dementia and significant disability due to cognitive impairment over time. Of course, addressing mental health conditions and stabilizing medical conditions, providing good chronic disease care and preventive care, keeping people out of the hospital or other institutional settings, and preserving their ability to move and connect with others as they would like to, giving them the energy to do so if they're not battling mental or physical health conditions. And also there's a powerful impact to addressing socioeconomic factors such as food insecurity, unemployment, providing support through social services and family services, and removing those barriers to social connection. We know that there is a feed-forward cycle between improving somebody's well-being in all of these respects and then therefore improving their connectedness, which in turn improves their mental and physical well-being. And unfortunately, the opposite is true. So it's very important to think of addressing the individual level, even just by connecting with the people around us, as either helping to set people up on an upward spiral of increasing connection that can contribute to improvements of well-being, versus the opposite, having increasing loneliness or increasing isolation, which affects people's health or wellness, and those two can also negatively feed into each other. So focus on the positive. Moving outward, we can consider an individual, but then the direct relationships around an individual as an opportunity to help intervene for the positive towards their connection and well-being. Some examples of this could include simply just making friends, improving relationships that maybe could benefit from counseling interventions such as marriage or family therapy, and overall just improving the quality of existing relationships or increasing the quantity or types of relationships, and your ability or other people around you's ability to connect to others. There are a couple of specific interventions that I'd like to mention here with regard to relationships, one being the 5 for 5 from Health and Human Services and the Surgeon General, and also a movement known as social prescribing. So the 5 for 5 connective challenge or connection challenge from the Surgeon General is promoted through the efforts to help address social isolation. And this is really quite simple. Anybody could do this. And I would encourage you all to try it. I tried it and found that when I was able to use a format like this to think of a way each day to either strengthen or improve an existing connection or make new connections, and carrying out that action, such as the example here, calling your mom to talk to them or reaching out to ask a friend to help lend you oh gosh, I actually did ask to lend a cooler for the trip to Colorado. And then also reflecting on the experience that you had with reaching out for these connections. The importance of reflection is that this helps to reinforce the benefit. And it's a kind of cornerstone of other behavioral interventions that can help us to be more likely to repeat these actions and make this part of our behavior patterns to do so in the future. Furthermore, when we reach out and form these connections with others, we do encourage other people to be more likely to do the same, perhaps with others in their network, so we can actually create a ripple effect via connection. Then there's another way of improving the number and quantity of connections on an individual level, starting from healthcare, which is called social prescription. Social prescription is defined as referrals from healthcare, usually primary care, to non-medical community resources or services in order to improve health by helping people to build and maintain social connections in these non-health related activities. As mentioned in my biography, I gained some experience with this working in Spain. The first of this work was done actually in Europe out of the UK in the 1990s, where people in primary care noticed the impact of loneliness and could really easily identify people as either lonely or at risk for being lonely based on the circumstances of their life, and then started referring people who would like to participate to an activity. In the first case, it was an art classes, a series of art classes, and formalizing this recommendation in the form of a written prescription to really emphasize to the patient that forming these connections and participating in activities is truly part of a healthcare plan and of addressing the healthcare problems that the person is experiencing and wanting to intervene on. This was successful and so has been replicated in many parts of Europe and also in the world. In my case, we worked in 2 rural community health centers in northeastern Spain, and we referred people based on their preference to different categories of evidence-based activities for improving social connection. These included creativity and the arts, exercise or physical activity, especially in a group setting, support groups, learning activities for people across the lifespan, volunteer organizations, or other groups that would help people to get out of the house and form social connections for health. The advantages of this are that it does promote collaboration and integration among multiple sectors, such as the healthcare sector and, perhaps arts or, education and nonprofit or other community sectors. But therein also lie the challenges. These formal programs do require quite a bit of effort and also, organizational and activity, a lot of collaboration with maintaining information to be able to facilitate these connections. And so it was very worthwhile, but somewhat challenging to implement, but very, very much possible as a way to collaborate between our healthcare settings where we really have the power to identify people who are either lonely or at risk for being lonely, and then help emphasize the importance of loneliness for health and improve the health of our patients in that way. So moving outward then from the relationships a person has to their community, a number of interventions on the community level, not even looking at each individual and their connections around them, can really contribute to the amount of connectedness to all people in the community. These can include public spaces, the presence or development of community organizations or group, improvements in transportation or accessibility throughout the community. And all of these things are known as social infrastructure. So social infrastructure is technically defined as community features that support the development and strengthening of social connections. And again, these include programs, organizations, services, policies, businesses, and physical structures of elements of communities that can help people to connect. When we think about rural communities, we mentioned that there can be some troubles with maintaining public spaces, maybe don't have as many parks or trails or walkable areas as more established or urban communities. There can be trouble with accessibility if things are not updated or maintained to make sure that they're available to people who might have health problems or disabilities or transportation barriers. And so this is really a key area for investment that all of us can promote, whether it's through, physical features or involvement in community and other groups that can affect the connections of others. Here's a number of examples of social infrastructure. Again, I mentioned public parks and public spaces, places that people can really go anytime, anywhere, whether or not they spend money, regardless of who they are, and have a chance of meeting other people. And also benefiting from things like being outside in green spaces or physical activity they might be able to do, such as walking. Restaurants and coffee shops are key to social infrastructure as they're places where people can either interact with the people in the business or often with others, either weak ties or casual acquaintances, or can arrange to have meaningful interactions and reconnect or connect with people that they have strong relationships in their life. Healthcare organizations and and social services are also really important to recognize, not just as areas where people can get care or interventions that can help their determinants of social connection, such as their personal health, but really as places where people who may not have a lot of opportunities to have other social interactions or may be isolated get to connect and communicate and work with others. This is particularly important, for example, for older people. And I think of many of my older patients who maybe these days aren't driving and walking and able to be as involved, and they do maybe spend more time coming to medical appointments than they do going to the activities that they would like to enjoy. And so for any of us that work in these settings, it's important to acknowledge that we are an important part of the social connections and social support, even in our limited interactions as we try to provide them care. Sports and athletic facilities kind of go without saying. If you have basketball courts or, a golf course in your town or, other areas, state parks that people can go enjoy the outdoors, this helps facilitate connection. Having living facilities such as assisted living, senior living, and nursing homes can really provide a lot of connection and reduce loneliness for people who might be older and experiencing barriers to connection. Businesses, not just as workplaces, but also as areas that people can frequent and go about their business, but also interact with others in their community and build and maintain those weak ties are very important. And the more businesses that you have within your rural community, where you have your community coming together to interact versus having to drive like we do half an hour away to the closest Walmart, we're not going to have the same experience shopping in our local hardware store where we will bump into people that we know and reinforce those weak ties as if we go to purchase the same thing at Walmart where we might have some interaction but we don't know anybody. Faith groups, churches, volunteer and community service organizations, which could be formal organizations like the Rotary Club or the Kiwanis or the VFW. It's a big community center where I live, but could also be informal, like groups that get together to help out neighbors. And libraries absolutely deserve a mention. They are one of the biggest areas that is a public space, open to everybody, where learning can occur, different kinds of programs, education. A community with a library is a lucky community, as this can really be a center of connection. So now I'd like to talk with you about a novel intervention, which we're going to call a prescription for coffee. Now, I know we're talking about a prescription and we're talking about coffee, so I want to clarify, it's not really that I'm prescribing coffee directly to my patients, even though we could have another talk another time about the evidence for regular caffeine consumption possibly reducing mortality from cardiovascular disease. The idea here is that this is an informal pilot program so far of a physical prescription, handwritten by me, prescription for one coffee at a specific place, which is an organization that is a really unique form of social infrastructure in our community, the Madison Mercantile. And the idea behind this is that it's kind of combining the elements of social prescription or a formalized, even though it's fairly informal, plan as part of a plan from a doctor to address a person's larger health, to go and seek non-health resources that facilitate connection. The reason why I'm prescribing coffee to the Mercantile and not just to one of the diners or restaurants in our town that do serve coffee is that this really is a truly unique business, or not business, a nonprofit organization that offers a variety of opportunities to connect really for people at all ages and stages in life. So more about the Mercantile. The woman that you see not wearing the stethoscope next to me in these pictures is Chris Shellstad, the founder of this nonprofit organization just a little over 2 years ago. To give you some background about this unique form of social infrastructure. Chris is originally from the community of Madison, Minnesota, lived many other places, including most recently Austin, Texas, where there are many forms of community, but then decided to move back to her hometown to really contribute to community life here. She is a woman with a mission. And so her first thought was, well, we're going to need some coffee because we don't have any, espresso in our small town in Minnesota. And she thought she couldn't be the only one who'd want coffee, but she wanted it to be more. So she was able to acquire a physical space that used to be a hardware store. So a very, very large space as a blank canvas to start with building a coffee shop. And then she wanted to have an art gallery where she could feature local artists. And then very quickly developed a stage where she started to have musicians, local or visiting, and other performance art groups putting on events and bringing people together. Screenings of documentary films then started. She then progressively built more and more spaces sort of based on the things that people were reporting that they need. There's a number of kind of cozy little rooms with bookcases and games and toys for kids that people can come to informally and share and meet each other, but that also can give space to host support groups. And there are a number of different support groups, including a support group for veterans and a caregiver support group, a cancer support group, among others. And then she thought, well, we have more space and there are people who want this support, but maybe would need more of a private setting. For example, to be able to have a marriage family session, therapy session via Zoom, or any other private uptaking. So there's a soundproof room for that. And then another one where there's music lessons. And then an exercise space that was built. And a personal trainer comes to town and says, hey, I want to try to start some personal training, and starts giving classes that actually incubated a business that moved out and became an independent business that is a wonderful, wonderful center of social connection and empowerment. But that's not enough. She developed also based on need, an area that's called the Men's Shed, which is a workshop type of area that opens a few times a week that local men and especially retired men come and can work on projects or tinker on things and get to see each other. There are everything from a space that a local person is using to grow like morel and turkey tail and oyster mushrooms to cultivate for sale. There's a farmer's market meeting there. There's a yoga space that just opened, and more things. And there's more and more people there all the time. So it says coffee, creativity, and community. But it is all of those things and even more than that, as you see some of the examples that I didn't even mention written on the right. So yes, the coffee prescribing is a form of identifying people who are either lonely or at risk for being lonely, and giving them a casual, no strings attached opportunity to connect with and experience this form of social infrastructure, and open the door to exploring many ways that they can build more connections and really positively impact the health of many people in the community without a single medication, right? And at no cost to those people. So not every community has a mercantile, right? But there are so many ways that no matter who you are, you can recommend or bring or help people around you in your communities to get out and connect with others around them. It's important to emphasize the strength, the interconnectedness of our communities, and the ability that we have, even through minimal interactions, to help support each other and lift each other up, while we also might work towards developing forms of social infrastructure that invest in our future and our community and can really improve health for generations to come. So, in conclusion, loneliness and social isolation are both very strong risk factors for poor health and premature death, while social connectedness improves mental and physical health. And while rural community members are at risk for social isolation and loneliness, there are also many strengths of rural communities, such as interconnectedness and cohesion, that provide us opportunities to address and overcome these barriers together. Healthcare, social services, and community organizations together, as well as individuals on their own, can play a vital role in identifying and addressing social connection. And rural communities can benefit from social infrastructure with physical space, activities, and groups that build our social connections to each other. There are a few resources that will be sent out from the National Library of Medicine that I recommend. The CDC has a whole toolkit on social connectedness and connection with many, many explanations and resources. And then the Commit to Connect Innovations Hub and the AARP Connect to Effect both contain kind of databases of different interventions and resources and ideas from all over the country. They have ability to filter among these interventions by different type and setting, or even by rural versus urban, so that you can see and be inspired by and learn from other efforts and other projects being done in communities like ours. They're really terrific resources. And thank you so much for your time or attention. It's wonderful to get to speak about this with you, and I'm happy to discuss questions.
Oh, thank you so much, Dr. Fields. Um, so far, we have had one question regarding sharing the citations for your references, which I know that you had said you would do. Um, and
Yes,
then,
I just linked them again in the chat. They're in a Google document.
terrific,
So yeah,
thank
it's
you.
right there for you guys.
And I can also send out that list of references when we email the recording to everybody who registered for this session as well. We also had a comment from an attendee who said that they have an initiative in their county, Weld County, which I think might be in Colorado. It's called Acts of Connectedness, and she shared a link to the information about this. And it's part of their effort to encourage social infrastructure agencies to consider how programs support connections. And she said that she's glad to know we are heading in a good direction there.
Excellent,
Um,
thank you.
yeah, I didn't see any other questions, but I had a couple of questions. I love the whole coffee prescribing, and I was just curious, one, if you've had any feedback from the patients that you've prescribed that to, if you've had any official interaction with them in a follow-up appointment, and if they've told you anything about their experience. And then the other question was if any of the other providers that you work with at Madison Healthcare, have they joined in and started doing the prescribing too?
Yeah, so the kind of informal tallies, I have written 12 prescriptions for coffee, which usually consists of a piece of scrap paper torn into quarters, right? It's very informal. And I write out in front of the patient RX for coffee from Dr. Fields, like at the Madison Mercantile, go to the Mercantile, get a free drink, check it out. And 10 of them have been used so far. So 10 of 12 people have already gone. 8 of the 12 that I have prescribed to, I have followed up with, and one had not gone yet, but still wants to. And the other 7 had already been and had positive experiences. And I believe all of those had then been back more than once for some reason, whether it was for another coffee or any other kind of event or service there. So so far quite successful. I have encouraged my colleagues, the other providers in my practice, to do this. I'm not sure if any of them have yet, but I'm looking at ways that we might be able to, gather data in a little bit more formal of a way and present this in a more formal way to my colleagues that they would maybe feel more comfortable with participating, and then that we'd also be able to have a better way of getting, quantitative information and ideally, right, confidential but qualitative information. So, we don't have a lot of our like IRBs and other things out in the area where I live right now, but these are things that I'm working out for the future.
Oh, terrific. Thank you. We did have one comment in the chat. Thank you for this webinar. It is so important to discuss this in rural communities at our community health center with our aging patients so they don't feel like they're going through situations alone.
Yeah. Oh, definitely. I mean, it does to everybody who is alone. Of course, you feel like you're alone in being alone potentially. And, part of, I think the, the hardest part in my experience with people who've really struggled can be sort of the real sense of pride that a lot of people feel in my community. And nobody wants to admit that they are having difficulty or struggling because of this. And so, back to the sort of coffee intervention, given that we do have this space that is accessible, it's wheelchair accessible, it's public transit accessible, and has support groups and even just friendly people, it's been helpful to just figure out an opportunity to just get people there to be able to realize that they're really not so alone and not lonely, and show them that there are ways to get over the barriers to doing something that has as little stigma as just going to get a coffee in a coffee shop. Yeah, and I see this comment, the aging population doesn't want to admit that they are lonely. Yeah, I could not agree more. And so
Mhm.
part of the power of talking about this is that it can really break down the stigma. And yes, help people know that this is not just them. There's a feeling I think that people get that loneliness is because of some sort of a personal failing, or there's something wrong with that person. And as you see here, right, it's not at all. It has to do with everything from processes in ourselves, right? Mental health or physical health, especially, that can affect us that we can't control, all the way up to greater trends in our society. And when we recognize that there is a problem, we have an opportunity to address this together.
We have two questions that are here, and I'd love to get to them. They're both really similar, so I'm going to read them at the same time. One said, we are challenged that our rural areas in Colorado are losing healthcare services. Do you have any insights on how to build partnerships when the effort is being initiated from outside of the community? And then the other question is, I work at senior services in Midland, Michigan. How do you get buy-in for these programs from the local health system? We have a friendly visitor volunteer program to connect older adults that are socially isolated. However, we're lacking volunteers.
Yeah. So let me just say that I do really, really identify with these challenges. It's it's hard to have one right answer. I can tell you, so from my experience, for example, when I worked on developing the program for my master's thesis in in Spain, I was a graduate student, a foreign graduate student, and I worked for kind of the state or regional Department of Health, but there was a lot of difficulty with getting buy-in from the medical providers in the community, and that step is really key. I think that depending on what kind of medical providers, their background and experience, they may not know as much or be as aware or inclined to, consider or intervene on the social determinants of health that are really as powerful as, the medical care that people get, right? Their life circumstances are maybe more determining of their health outcomes in general than the care that people receive. And it can be an opportunity for education in the healthcare community. As a public health doctor, working among other doctors and providers, I acknowledge that my own experience and background has given me a lot of opportunity to explore this, and it's just not true for everybody else. And yeah, healthcare systems are significantly strained. But the truth is that if you can do some education, especially, getting stakeholders like medical providers involved in things like, look, like, how you don't have enough time to help address social isolation in your visits. And that people who are more isolated are going to experience more pain, right? They're going to have more appointments with less, medically intervenable causes. That being able to identify people who are basically lonely and connect them or recommend that they do anything to connect and address their loneliness and social isolation, it actually decreases the burden on a healthcare system, including a rural healthcare system that might be quite strained. As far as Coloradans losing healthcare services, yes, I'm very familiar with this. I worked in community health in Colorado prior to Minnesota, and there are really, really big disparities in health between urban and suburban areas and rural areas in Colorado. Are you saying that the effort initiated out from outside the community is like a group trying to influence social connection that is reaching out to rural communities? Because, from the perspective of someone trying to intervene and get stakeholders like medical providers involved, I think that actual contact and that same relationship and connection, as difficult as it might be, showing up and going out and talking to people, and like I said, emphasizing how much you're on the same team, and also what medical providers who are balancing a lot of really, challenging competing needs and a lot of strain could have to gain by working as a team and not being alone or lonely themselves in addressing these real community-wide factors. And so I would encourage, dialogue and building social connection. If you're trying to go out to any healthcare providers and get them involved, it might help to bring them some coffee, again, prescribing coffee. But it's these simple acts of sharing and forming ties and connection and reinforcing these that can help to build that trust and help get people who are in these strange settings to actually try these interventions, try using these resources so that they can see how it helps their patients and helps them. I would be happy to, to talk with you more about any specific information. And like I said, I thank you for everything that you're doing and for trying to address these things in ways that are important in settings that are truly challenging. And building partnerships is challenging, but it's key.
Thanks for watching. This video was produced by the network of the National Library of Medicine. Select the circular channel icon to subscribe to our channel, or select a video thumbnail to watch another video from the channel.